Hello, everyone. My name is Mariam Ashfaque. I'm from Pakistan, and I'm currently a clinical research student at the University of Chicago. Today, the presentation is about one of our publications, Consequence of Diabetes mellitus in Bone Health. The main goal of the today talk is to spread the awareness of the osteoporosis so we can identify this disease earlier and can be avoid the mortality and morbidity related to this disease. So the four main objectives of the today talk is first to understand the risk of the fragility fracture and the importance of early screening of osteoporosis in diabetic population. Understand the pathogenesis of impaired bone quality and mechanism, how it causes the bone fragility in diabetic patient. Understand the role of anti-diabetic medication and their impact on bone metabolism and fracture risk. And understand the various bone biomarkers and the new imaging technique which helpful to check the bone strength or detect the early bone disease. So before we go to the pathogenesis and the other anti-diabetic medications, so we see how the big problem it is. International Diabetic Federation mentioned the worldwide diabetes mellitus affect 537 million of adults in the age group of 20 to 79 years. So it means like everyone in the 10th is suffering of the diabetes, and this estimate is going to be increased about 46% in next 25 years. According to the IOF, the osteoporosis actually because affected one in every third woman and one in every 5 men over the age of the 50. And it's causing the 8.9 million fractures annually, and resulting the osteoporosis means you can say that every 3 seconds the fractures is occurring due to the osteoporosis. Prevalence of the fracture and diabetes mellitus. So many studies mention that both type of the diabetes, they increase the risk of the fracture and they can affect any side of the skeleton, the vertebrae, but particularly the hip fractures are more common. The effect of the diabetes on bone is very complex, and the multi-factor contribute to increase the risk, include the duration of the diabetes, drugs, secondary falls, it might be due to the complication, insulin use, and the glycemic control. So if we see, means like we all know the screening we use for the osteoporosis gold standard is DEXA. But the thing is the bone mineral density may not reflect the bone fragility in the diabetes mellitus. The bone mineral density actually increase in type 2 diabetes mellitus in spite of increase the risk of fracture. So it is not like a very good indicator or a good tool. The FRAX tool is also, we need to be adjustment. So they underestimate the risk. So patient should be screened for osteoporosis with other imaging techniques like TBS, is the trabecular bone score. This one is the new one. And in addition to other prevention of measures. So this is just show the what is the means like this is the calculator FRAX tool to estimate the risk of the fractures. It include the risk factors and secondary causes of osteoporosis, but we need the adjustment of the DEXA and the FRAX. Here, to understand the pathogenesis, I'm just going to just quick overview of the bone. The bone structure is very complex. It's mainly contain the two tissues, the trabecular and cortical. The cortical is the compact one. Outside the trabecular is a spongy bone, and they differ in their microarchitectures and porosity. And the bone is composition of the matrix and the cells. The matrix is the organic part and inorganic part. The organic is collagens. They are cross-linked to each other. The main collagen is type 1, and inorganics, they are like the mineralization is mentioned, the bone density, and the most many cations and anions, the more common are calcium and phosphorus. 4 kind of the cells, and these cells are osteoclast, which is to cause the resorption. Osteogenic cells are stem cells, which make a new cells. Osteoblast cells, which form the bone matrix, and the osteocytes with the 90% of the cells, and they maintain the bone tissues. So the diabetes actually affect the bone health in the many ways. The one is they are decrease the bone turnover. What is bone turnover? What is bone remodeling and modeling phenomenon? This is the normal. This is means like occurring in a 4-step. Whenever there is a damage of the bone have a capability continues to making a new bone and resolve the bone. So there is like activation, for example, here The activation of mechanical or biochemical stimuli when occur, they cause the micro cracks, which remove the membrane. And then osteoclast comes and they have a very different stimuli, and this osteoclast resolve and digest the underlying bones. And then the osteoblast is moved and they make a new lining, bone matrix, you can say, and which later subsequently is calcified. So here is the just a little picture how the type 2 diabetes affect the bone quality. So it is decrease the bone, you can say disrupt or deteriorate the bone geometry. They increase the cortical porosity, which is the part of compact bone, and it is decrease the trabecular bone score. So they overall means poor the bone quality. And instead of they overall actually decrease the low bone mass, this low bone mass and the poor bone quality contribute to increase the fragility fracture. Okay, here we going to pathogenesis. So the pathogenesis actually how the diabetes impaired the bone quality and increased fragility. So first of all, I think the one factor, there's multifactorial, it's very broad term. The altered body composition, BMI in a type 1 diabetes, which affect the young population, have a lean body mass, which can be contribute. And then altered bone strength. So there are many ways. They altered the bone turnover, modeling and remodeling phenomena. They disturb the microarchitecture changes, and the hyperglycemia, the excess glucose, which cause the formation of AGEs, is advanced glycated enzymatic production, and they cause the deposition on the bone matrix. So the one well-known one is the pentosidine. So actually AGEs are forms physiologically due to the agings, but in the diabetes there are more production of the AGEs, and they affect in a different way. The first, they make the cytokines, inflammatory cells, which delay the healing. They disrupt the osteoblast, means they cause the deterioration, the osteoclast activation, and they also lead to the microvascular complication. So in this way, they accelerate the development of osteoporosis process. Okay, so there is the complication of the diabetes. We know the acute complication, chronic complication, the chronic long-term complication, especially microvascular related, it is neuropathy, retinopathy, and nephropathy. They are actually indirectly lead to the fractures, which increase the risk of the falls, reduce vision, is contributed, imbalance problem, immobilization, cause the weakened bone. But the nephropathy is the very important one. The adverse effect of the impaired kidney, like the inactive of the vitamin D, loss of the calcium, and uremic osteodystrophy. Medication is very important. There are whole classes of the diabetic medications we use. So I'm going to just superficial to just give an idea to which one is like have a positive effect of the bone and which one is have a negative effect of the bone. So we can make our choices, means like which medication we can choose in the diabetic population who have a like increased risk of the fracture. So metformin is a first line drug we usually used for the diabetes. The many studies mention and also the research, the metformin is very effective, it's very safe. It is also have a positive effect of the bone through the AMPK pathway. This one is, we can say like we prefer to use the metformin in the diabetic population. And the other is the DPP, is the dipeptide peptidase, and the glucagon-like peptide receptors agonists. These also have a neutral effect and positive effect. GLP, the brain curiosity we use in USA, but we have except of the exenatide. So these two also have a good contribution. And TZT, there's one clinical trial which mentioned that these are pioglitazones and rosiglitazones. They have adverse effect. Adverse effect, they can cause the bone weaken with the various phenomena. And the SGLT2 inhibitors is sodium glucose cotransporters class. These two have adverse effects, so we use with the caution. And if we see insulin and sulfonylurea, so insulin actually have an anabolic. It is an anabolic hormone, have a like positive effect on the bone, but these both are indirectly increase the risk of the fracture by falls. Okay, and then here these slides actually show the bone biomarkers, gene expression markers, and imaging techniques. So there are a lot of the biomarkers. I'm just choose to focus a few of one. Pantosydins are AGEs, and this is we can, if it is increased in the serum and the urine. So they mentioned it means like if the diabetic population, so it's related to the bone strength, and the studies some shows means like if it is increased, their risk of the vertebrae fractures and the other fractures. And the one is the sclerostin. Actually, this is the we can say bone resorption marker, which is increase in diabetes. Osteocalcin, it is bone formation marker, which is decrease in the case. And there's a lot of the markers, but I have a time limitation. So let's move. Okay, independent of the imaging techniques, these are the DEXA mentioned, where we do the T-score and Z-scores measure the screening, but this is not a good indicator, or if we can say the poor marker for fracture risk in the diabetes. So we have a new techniques. This is the TBS. This is like recently developed analytic tool, and this is like 2D DEXA, which is would take the picture from the lumbar spine, and this is actually independent of the bone mineral density, clinical risk factors, and the FRAX tool. Here is the two means compare the two patients, the one having a normal trabecular mass, and they show the homogeneous means the gray level texture measurements, and so high TBS. And here is the they show the degraded the vertebrae. Degraded system means like they have a loss of the trabecular mass, and they have a low TBS, and they show the like this picture. Okay, and then we have so the thing is the TBS actually measure of the trabecular component of the bone, and the CT is the if we go to the CT, which is high resolution CT, this is the 3D imaging. This is 3D imaging, and sorry. This is 3D imaging, and it's measured both the cortical and the trabecular components. And this one is show the micro CT scan of the distal radius. This is like advanced imaging, which is very helpful when the DEXA means like it's a poor indicator, and FRAX tool too. So MRIs also do the trabecular and cortical components, and there is a micro indentations. This micro indentation is the clinical test, is the osteoprobe, which performed on the mid diaphysis of the tibia, and is the measure the bone resistance, and it is reduced bone resistance in the bone resistance in the diabetic patients. Okay, this one is show the bone imaging roadmap, in which the steps of increasing values means like how far we move from the body fluid biomarkers of bone formation and resorption, and from the DEXA to the high resolution imaging techniques. Okay, and so these are the key points of the presentation. The type 1 and type 2 diabetes mellitus both increase the risk of the skeleton fracture. Bone mineral density underestimate the risk in the development of type 2 diabetes. Type 1 and type 2 diabetes have a common mechanism such as AG's deposition and bone microarchitecture defect, disturb the bone turnover mechanism, microvascular complication. Metformin medication is more safe and effective, and the TZD increase the fracture risk in the person with type 2 diabetes mellitus. So the primary care practitioners in the and also the endocrinologists, they're more vigilant to address the fracture prevention in the diabetic patients with the other preventive screening. Okay, thank you.